An important clinical question in the volar approach to the distal radius fracture involves whether or not the restoration of the normal volar tilt of the articular surface is relevant to overall function. Really, we see three different sorts of post-surgical radiographic findings. There may be still residual volar tilt in neutral, or it may be dorsal. Bear in mind when there's a dorsal displacement and it heals as such, it's the angle that it is displaced dorsally must be included as well of the normal angle of volar tilt. So it's the displacement is actually more than we measure on the X-ray. As we'll see, the important aspect of whether or not the alignment of the end of the radius with regard to the volar tilt correlates with the relationship of the carpus, the capitate lunate axis, and the end of the radius. So we see here at 6 weeks a radiograph showing the initial X-ray in the center and the restoration of the angle, which in this case measures 20 degrees. We see an additional case where we're looking at an attempted measurement. However, notice from the sagittal X-ray that it's not a true lateral, and this may make it a little bit more difficult to truly assess the volar tilt. In this case, for example, we can see that the restoration of length has restored the relationship of the distal radioulnar joint in the frontal plane X-ray. And if we draw a line taking the capitate lunate radius axis, we see that it's within its normal position. Thus, the normal carpometacarpal hand to radius force bearing is probably within normal. Here's another example, a more complex fracture with a split lunate facet that we see a loss of the tilt. So when we're measuring 12 degrees, we have to really add anywhere between 5 to 14 degrees of normal volar tilt. So this might be displaced about anywhere between 17 to 20 degrees. Again, this is a bit of an oblique view, but the important thing is the relationship of the carpus to the end of the radius. In this case, you see that the lunate is actually extended. Now it's extended, and this is the capitate axis. So this may present a problem with either pain or loss of grip strength because of this malalignment. And so we have to look at then what this means. What's the so-called anatomy of the volar tilt loss? If we look at what happens when we apply a volar plate, especially with a large dorsal defect, there may be a tendency either initially or over a subsequent time for this to settle down. One of the questions that may be is how many screws are necessary to avoid this, and should the screws extend into the dorsal cortex to provide more stability? This is what we don't want to see occur if we're intending to try to maintain this normal volar tilt. And what this does, if you carefully look at the volar plate, when this occurs, not only have we jeopardized the normal relationship of the carpus to the radius in weight bearing, force bearing, but also now look at the plate. The plate is now off of the bone and represents a major risk of tendon problems. The ICUC app has documented a number of cases of many fractures, but in this situation, 186 of distal radius fractures, looking at specifically this particular problem. All of these cases are documented by preoperative X-rays and CT scans, postoperative X-rays and CT scans, complete intraoperative operative technique, and followed to union and ultimate function anywhere between 40 to 60 weeks in some cases. So let's look at this case here. This patient, the immediate post-op x-ray, we would feel that there's a good relationship in the sagittal plane of the volar tilt. At 27 weeks, there's a little bit of a change. The volar tilt went from the palmar direction, now you might say a neutral. However, if you go back and we carefully look at this x-ray, we see that it is an oblique x-ray rather than a true sagittal x-ray, and here it's a better x-ray. But the fact is that we have a change. Functionally, this did not present a problem, and so we have a neutral volar tilt with a good function both in the carpal kinematics as well as the distal radioulnar joint. Here we have another case with a little bit more complexity with an unstable distal radioulnar joint, but in the immediate postoperative x-ray, we have a normal volar tilt. And we follow this along. Notice there's a defect on the radial side where the bone hasn't completely filled in, but we maintain a reasonable volar tilt in the sagittal projection. And this case, the lack of full supination reflects the injury to the distal radioulnar joint. This third case illustrates postoperatively a very acceptable volar tilt in a good sagittal projection. At 26 weeks, however, that has changed and we're in a more neutral volar tilt. Here we see a good functional result, but what we don't see in some of these motion follow-ups is whether or not it affects grip strength. And that's the point about the relationship of the capitate lunate axis to the end of the radius. So it seems for the most part that if you have a neutral volar tilt, it's very acceptable in maintaining that important axis. Now here's another example. Notice that we see a little defect here, but a major defect here. Notice that even at the initial post-op x-ray that the capitate lunate axis is a little abnormal with the lunate extended. And over 33-week follow-up, we've lost any volar tilt, and we're starting to see a change toward the dorsal tilt. Functional result. Another example, post-op change. Here, 79 weeks, this has settled. And in this case, we see a loss of full motion, good extension, but a lack of full flexion. Whether or not that's related to the tilt is hard to know. Another example where initial x-rays show a failure to regain the volar tilt, and this persists and does have some lack of flexion again. One more case showing situation with this big gap here. Initially, the volar tilt is quite good, but over the course of union, this has settled and importantly has put this plate as a more precarious situation with the underlying flexor tendon. So if we look here, initially plate may be a little prominent, but here it's quite a bit. However, at 26 weeks, there's no functional problem. However, we would caution a situation that this might be a problem later with a tendon rupture. And the final case with a very complex 4-part intra-articular fracture. And we see the initial x-ray is not really restored the volar tilt. The lunate is extended, the capitate is displaced. The post-op CT scan shows the screw on the ulnar facet capturing the dorsal lunate facet, and that may prove to be important in preventing loss in some cases. But look what's happened here. The volar tilt has led to a substantial extension deficit, and because of that, you see the screw has broken through the articular surface. And so in this particular example, this has become a problem with the intra-articular screw and the potential of disruption of the sigmoid notch and the potential of making the plate a little bit more precarious for tendon rupture. And what happens is that if we superimpose a pre-op, meaning green, to post-op follow-up, we see in some cases what the screw placement were in the subchondral bone. Because of settling, they're now not in the subchondral bone, not providing that support, and it has moved more proximally in the metaphysis, which means that the fracture has settled as well. And at 47 weeks, we see a substantial loss of volar tilt. Functionally, this may, again, or may not be a problem, but the loss of volar tilt may not reflect motion as much as strength if it impairs any degree of outcome, because the capitate lunate axis and its relationship to the radius may not be satisfactory. This is a metaphyseal defect. Here's the immediate post-op where we have a nice volar tilt, and we have seen clearly settling over the course of healing. And at 5 weeks compared to 47 weeks, really no major change. The CT scan, however, shows that the screws now are relatively impinging on the articular surface. And so in summary, it's very important to realize that despite having screws initially placed in the important subchondral zone, where there's a substantial metaphyseal defect in these osteopenic patients, there is a chance of settling over time. The results of these may or may not affect overall radiocarpal motion, but may affect overall strength, because the carpal radius alignment may be off. In a more difficult situation, the screws may then penetrate the articular surface. So it's actually very important to follow patients post-op. There have been some suggestions that after 2 weeks, there may not be a need for subsequent x-rays. It's probably not the case. And at least an x-ray at 6 weeks and then perhaps a follow-up may be very relevant, because things can change.
With the belief that more transparency in the practice of medicine will enable substantial progress, ICUC is launching a cutting-edge app to improve learning of surgical procedures in orthopedics. The app gathers complete, unchanged and consecutive series of surgical interventions. Independent orthopedic surgeons record the interventions from pre-op to functional result to ensure complete recording, including surgical shortcomings. Download the app from the Apple App Store and access for free to a broad library of orthopedic case studies. Try ICUC app and discover a new learning experience.